Hello, ISR community. I think you can hear me, right? It's working. That's so exciting. We're actually going to be revamping some of our audiovisual equipment in here, but it's good to know it's still sticking with us. In the interest of time, I'm going to go ahead and get us started so that we can have our shotgun time. Great, thank you. I'm Kate Cagney. I'm the director of the Institute for Social Research here at the University of Michigan. I'm so glad you could join us here for our Insight Speaker Series. This is a forum for ISR faculty to share the research to inform the public good, and this is certainly a great example of that form of work today. I want to tell you a little bit about ISR. We have over 300 affiliated faculty who conduct research that addresses topics such as wealth and inequality, race and racism, politics and public opinion, as well as a wide range of other topics, including teen drug use, economic behavior, aging, health status. That's going to be a focus of our presentation today. A full schedule of Insights talks is available on the ISR website, as well as recordings of past talks in the series, should anyone want to access those. We'll post a video of today's event there as well, so in case you want to review anything that you have learned. So let me tell you a bit about today's talk. I have the pleasure of introducing our speaker, Ola Rodstant. She's a research investigator in the health and retirement study here at ISR. Ola's research focuses on cognitive aging and mental health among African Americans, latent growth curve modeling, and measurement invariance of health outcome measures. Today, she'll describe her research exploring the connections among hearing and tooth loss on cognitive function, so those three key components, using data from the HRS. The relationship among these factors is complex, as I think Ola will share with us, but recent work has contributed to our understanding of the unique challenges faced by an aging population with detriments in health like those she will describe. So we'll have time for Q&A at the end of the presentation, and Ola actually prefers that she move through the slides, and then we save our questions until the end. So unless there's something quite burning, that's the model we'll go with. And so with that, I'd love to turn things over to Ola. Welcome.
Can you hear me? Okay. So today's presentation is a soundbite on cognition, how hearing and dental health impact cognitive function. I sort of came to studying oral health in a really strange way. Prior to coming to ISR and University of Michigan, I was at the National Institutes for Aging, and there are not a lot of social scientists on the intramural side. It's mostly bench scientists. So I had a lot of bench science friends, and one of them came and rapped on my door one day and said, I just went to a talk on rats with no teeth who have dementia, and you should think about that with people. And I was like, what a bizarre idea. But I wrote in my lab book, and here I am. So I'll get started. So we all know that Alzheimer's and related dementias are a significant public health issue, both here, both now, and in the future. So in 2015, over 46.8 million individuals aged 60 years and older were living with dementia. This number is projected to double every 20 years. And projections estimate a substantial increase to 72 million people by 2050, posing a significant burden on the healthcare system in terms of disability and associated health costs. Okay. Projected global impact of ADRD. So Alzheimer's and related dementias are expected to affect more than 152 million individuals globally by the year 2050. This projection emphasizes the urgent need for comprehensive strategies addressing prevention, care, and support to manage the increasing challenges posed by these conditions. So there are a myriad of risk factors, everything from race to alcohol consumption, obesity, diabetes, hypertension, brain injuries, depression, pollution. You get the point. But two areas that I think are we don't have a lot of focus on is hearing loss and tooth loss and their relationship to cognition and cognitive health. So hearing loss is a widespread condition affecting over 400 million individuals worldwide, according to the World Health Organization. And the incidence of hearing loss significantly increases with age, nearly doubling every 10 years of a person's life. Approximately 8.5% of adults age 55 to 64, and those age 65 to 74 and 75 and above will experience some form of disabling hearing loss. Among adults age 70 and older who could benefit from using hearing aids, less than 1 in 3 have ever used them, or they use them inconsistently. With age, just naturally, there's a decrement in both peripheral and central auditory processing. Peripheral is the transmission of sound through the outer and middle ear, and the central auditory processing involves the decoding of sound through higher levels of the central auditory nervous system, so the brainstem, the midbrain, the auditory cortex. Approximately 8.5%, oops, did I do that wrong? Yeah. Hearing loss and cognition. So what's the relationship? What do we know about it? There's several mechanisms that have been posed to explain the relationships that are found in the literature. One of them is overdiagnosis. So older adults are less likely to seek help for hearing difficulties or use hearing aids often or consistently. And there are times when people need a hearing aid or they're dealing with some sort of decrement in their hearing, and they're perhaps being evaluated cognitively, and they won't ask for clarification, they won't ask for amplification. So we have an issue where there's an artifact of hearing loss and not necessarily a cognitive decline. Another mechanism is neural degeneration, which is related to just age-related changes in hearing, vision, and cognition that all of us will experience at some point in time, if we're lucky enough to age. And it reflects what's referred to as a common factor. And this common factor suggests that age-related changes are comprised of both a central and a neural component. Another mechanism is sensory degradation and deprivation. So hearing loss results in a degradation of inputs to the brain, affecting the audibility and the clarity of sound. Peripheral hearing loss hampers the quality of sensory information reaching the cortex, leading to a deficiency in the information's quality. Over time, this degradation contributes to changes in the structure and the function of both the auditory and the cognitive systems. Increased neural resource allocation. So in the presence of hearing loss or external noise, more neural resources are required to process degraded auditory systems. So basically, you're working really, really hard to try and hear things. The increased allocation of these neural resources to degraded signals leaves fewer resources available for higher level cognitive processes, such as working memory and recall. With respect to tooth loss, there are unique challenges that face older adults. One of the most important is that we don't have Medicare coverage for routine oral health benefits, which then impacts access to care for older adults, and as well as the impact of polypharmacy. So people taking multiple medications for multiple conditions can have an impact on the health of the mouth as well as the teeth. Dentalism trends, and dentalism is basically tooth loss. So the loss of all natural teeth is often the result of severe dental caries and periodontal disease. While the prevalence of dentalism in the US has decreased over the last 5 decades, disparities in tooth loss still exist. So there have been several factors associated with the decline. Most of it is attributed to good prevention services like fluoride treatments and more tooth preserving approaches. So disparities continue to exist despite the decline, and they exist specifically with economically disadvantaged older adults. And with respect to race and ethnicity, we see this with low-income non-Hispanic whites and Black Americans facing a higher prevalence of indentualism. So what's the relationship between tooth loss and cognition? The impact of chewing ability on nutrition and cognition. So compromised ability to chew based on tooth loss or tooth pain can lead to a decline in the quality of one's diet, resulting in poor nutrition. So people are not consuming a nutritionally dense diet. They're unable to do things like chew on nuts or hard vegetables or fruit, etc. And that poor nutrition in turn has an impact on the central nervous system functioning, including cognition. And when you think of it as sort of an arc, someone who has a poor diet predisposes them to things like obesity. Obesity then exposes you to something like cardiovascular disease, which then increases your risk for Alzheimer's and related dementias. So the role of tooth loss in chewing and oral health. Increased tooth loss reduces the number of intercallosal contacts. So basically where our teeth on the top and the bottom touch, affecting the ability to chew food and to speak clearly and maintain a healthy bite. The final pathway is focused on the inflammatory pathway of the central nervous system. Suggested mechanism involves a common inflammatory pathway where chronic periodontal inflammation leading to tooth loss may exert effects on the central nervous system before tooth loss actually occurs. Some people in the literature refer to this as the breaking of the blood-brain barrier. And there's an intersection that is not really dealt with in the literature, but I've been able to examine it with HRS, where we look at the relationship between tooth loss and hearing loss. So the size and shape of the ear canal, the assertion tube, a tube that connects the middle ear to the back nose, and the way sound resonates and vibrates can be affected when you lose your teeth. So literally sound is carried through our mouth. So without teeth or bony structures, you lose that. So when the height of your bite, the vertical dimension of the occlusion, or how the top teeth and the bottom teeth touch, is lost, these effects on hearing become even more noticeable. So the role of teeth in conducting sound, which is something I never knew before I started this work, is that teeth are believed to help carry and enhance sound by vibrating. This enhances what is known as bone conduction, where sound travels through the bones. And the vibration from instruments was used to show that sound can travel through teeth to reach the inner ear. And this concept is called dental hearing. So you can imagine if you lost your teeth, it sort of compounds things for you with respect to hearing. So to get to the current study while we're here today, I decided to examine, does tooth loss mediate the relationship between self-rated hearing and cognitive function? So does tooth loss explain that relationship? I did this using the Health and Retirement Study, as many of you know, which is a population-based, nationally representative epidemiological survey of adults in the US aged 50 years and older. This particular study, I used data from 2006 and 2008. The measures used were a cognitive function measure, an HRS called the telephone interview for cognitive status, or TICS. This measure is comprised of items that reflect participants' ability to respond to episodic memory, working memory, attention, and processing speed. The overall cognitive performance was measured by summing the scores of these subscales, and they range from 0 to 27, with higher scores representing better cognition. Self-rated hearing was assessed with the question, rate your hearing poor to excellent. And tooth loss was assessed by asking participants, have you lost all of your upper or lower natural permanent teeth? Standard covariates, age, race, marital status, sex, educational attainment, and smoking status. Analytical approach that I use, or we use, was a multiple group path model using maximum likelihood within M+ software. And the model was first estimated in the entire sample, and then separately for men and women and non-Hispanic whites and Black participants. We then tested in a sequential manner whether the model paths, the direct and indirect paths, differed by sex and race using likelihood ratio tests for the decrease in model fit after constraining each path to be equal between sets of groups. So basically, it's a moderated mediation. Basic sample demographics. This sample, N was 7,472 individuals. Average age was 68. 58% of my sample was female, 86% non-Hispanic white, 14% Black, 35% with at least a high school education, 65% of them were married, and 36% rated their hearing as good. The average cognitive score was 15.2. And these were the three main findings from the full sample analysis. So people who reported having higher self-rated hearing also had higher cognitive scores. And on average, persons who had indentialism or tooth loss had lower self-rated hearing, and persons with indentialism had lower cognitive scores as well. The indirect effects were significant, indicating that tooth loss does mediate and explain the relationship between hearing loss and cognitive function. I then looked at that model by race, and the multiple group analysis where we tested the equivalence of each path across groups were all non-significant in that the individuals, the model held for everyone. So there weren't any differences based on race in terms of how this model behaved. So you can see for whites and Blacks, it's both significant with respect to higher self-rated hearing and higher cognitive scores, but slightly more robust for Black Americans. For persons with indentialism that had lower self-rated hearing, we see that it was a stronger relationship for whites. And with persons with indentialism that had lower cognitive scores, it was more robust for whites. The indirect effect was significant for both groups. And I looked at the model by sex, and we can see that for the first question with self-rated hearing and cognitive scores, significant for both groups, but more robust for men than women. For persons with indentialism who had lower self-rated hearing, it was a stronger relationship for women than men. And that's a little bit curious because in the literature, men tend to have more hearing loss than women do. So who knows? Persons with indentialism had lower cognitive scores, and it was a stronger relationship for men than for women. And both of these mediation relationships were significant and almost equivalent. I feel like I've talked too fast, but here we go. So next steps. There remains a lot of problems with respect to this work. There's a lack of consistency in the hearing and cognition literature in terms of how hearing is measured, whether it's audiometric or a self-report like what I used. So it's something that we should really think about having some sort of standardization in studies that are based on this particular area. And it's the same thing with tooth loss. Some of the data is self-report, some of it is based on dental exams like in NHANES, where you can look at number of teeth and not just someone saying, I just don't have teeth. And then there's always the vexing problem of measures of cognition, that many of these instruments don't behave the same way in non-white populations. And in this study, I used cross-sectional data, but of course, we really should be looking at this in a longitudinal frame to see how this sort of develops over time and what those trajectories might look like. And another issue is to think about this in terms of evaluating the role of geography or urbanicity. Like I'm a native New Yorker, so in New York's lit up like a Christmas tree all year round. It's noisy, it's constant stimuli. And I've wondered like whether or not, traveling on the train most of my childhood and young adulthood has impacted my own hearing from the screeching of the trains and the buses and just the human chatter. So that's something that I personally would like to explore as I extend this study. And I have to make acknowledgements because your colleagues are your cheerleaders, your colleagues are sometimes the people who say, I really think you need to do that, et cetera. So I really wouldn't have been able to do this work without these individuals. Thank you. And I'll take questions now.
Around with the microphone if anyone has a question to ask.
Hi, really interesting subject. Can you explain more what you mean by the indirect effects line? Like, how is that processed? I'm having trouble thinking, like, does it mean that tooth loss goes to hearing, goes to cognition, or what was the order of that again? Thanks.
Great question. So with respect to this model, this is a standard mediation model. So the direct effect, well, let me explain the model itself. Self-rated health would be considered the X variable. Tooth loss is the mediator. Cognitive function is the outcome variable. The arrow that goes from self-rated hearing loss to cognitive function reflects a direct effect. And the relationship, if you look at the arrow that goes from self-rated hearing loss through tooth loss and then to cognitive function, that's the indirect effect. So tooth loss is explaining indirectly the relationship between self-rated hearing loss and cognitive function.
That's still like close, right? Yeah, like you don't know if it's causal or not.
Exactly. I'm not just association.
Yeah.
Thank you.
Reflecting on the notion of self-rated hearing loss, and of course, it would be nice if there were other ways to test the hearing, but I also wondered if there are any examples where a partner is queried about hearing loss. of the focal individual, because anecdotally, I think, right, we know circumstances in which people believe that their hearing is actually quite effective, but a partner is right augmenting or right or actually translating other sorts of things. And so I just wonder if there are any examples of that.
I have not found any, but it definitely tracks with other health issues and couples. And it's definitely something that I plan to explore in HRS with the dyads, because that's a wonderful point. You think you're hearing everything, but it's really your partner that's sort of the great equalizer, so to speak. So yeah, that's a great question.
Have there been studies using audiologist tests to confirm or retract, whatever, the correlation with cognitive function?
Yes, work by Frank Lynn at Johns Hopkins using the Baltimore longitudinal study. They've had a lot of cutting edge work using audiometric measurements, examining the relationship between hearing and cognitive function. But I've only found one published article that has looked at the mechanism of tooth loss before mine.
So do dentures conduct sound as well as real teeth?
Sorry, could you say it one more
Do
time?
dentures conduct sound as well as real teeth?
That's a great question. They do not. They do not.
And I actually have another question too. On the first slide that you showed, it said that dementia rates are expected to double within the next 20 years. Why is that?
I think probably a certain amount of it is assessment. So a lot of times people may have had symptoms related to cognitive decline, but they were attributed to other things. But we're far more sensitive today about those changes. So I think similar to something like autism, where there's just a lot more assessment going on. So we're able to catch things earlier, not to fix it because we don't have a cure, but to sort of help in people adjusting to the stages of the process. But to follow up on your first question, dentures, I mean, nothing's better than our natural teeth, but implants are superior to dentures.
That makes sense. Because
They're rooted into the.
So I don't know about traditional Medicare, but I believe, at least in Michigan, with the Advantage plans to Medicare, finally, they do have dental and vision. So there's some progress along the lines. Question was, did the study cover combinations of hearing loss versus not loss of teeth and vice versa, and the effect on cognitive abilities, and also was socioeconomic status taken into consideration in terms of those people who had those deficits and that impact of that factor on cognitive abilities?
Okay, so I'll start with your last question, and I should have said this. All of these models control for age, sex, education, marital status, and smoking status. So in terms of SES, yes, it's controlled for in the model. So these estimates are holding those things equal. And then your first question.
Combinations of hearing and versus not losing teeth and vice versa, and impact on cognition.
I wasn't able to do that with this study because of the variable that's used for hearing. It's a Likert scale, so it's not really easy to say someone is hearing or not hearing, because it's self-report and it's people saying how they view their own hearing. But that's a wonderful extension.
Other questions? Oh, back here.
So I'm a psychiatrist, and I've been aware of the correlation between hearing loss and decline in cognitive function from a number of studies. I'm not aware of a connection potentially to tooth loss. And you asked people in one part of the study, or someone asked them, if they were edentulous, meaning totally edentulous. But of course, often patients come to us with, missing a few teeth. And it seems like it'd be a place for a good study to how many teeth you have to lose for it to have an effect on their cognitive function. Because people often, lose one or two at a time.
It's incremental.
And there's also a connection with tooth loss and abuse of certain substances,
Yes,
such as crack cocaine, which can kill the teeth.
right, and meth.
Other questions?
How good are the data in terms of the timing of the tooth loss?
I'm sorry.
The timing of the tooth loss? How do you know at what stage they're losing various?
Not with HRS. This question on dental health only started in 2006.
Oh, okay.
Yeah, so there's no way to really track how, whether a person, when we interviewed them, they had just lost the rest of their teeth.
Okay.
Or, yeah. So it's a measurement issue.
Yeah, I was interested in its association with other kinds of health decrements, but also potentially things like labor market participation, and other things where there's a small literature, as I understand it, that suggests that people retract, right, when they don't have the self-presentation necessary for certain kinds of roles. So if one is losing, right, all of one's front teeth, then it makes certain jobs not as accommodating.
Absolutely. A lot of the literature, at least with relationship to not self-rated, but hearing loss and cognition, the mediator, what explains the relationship has been things like isolation and depression. And that comes along with if you're, unable to present yourself to the world in a way that you feel comfortable with.
One more time, if there are any other questions. And if not, we'll thank Dr. Roskett. This was an excellent talk.